organization that represents the professional society. My heartfelt gratitude and thanks to Dr. Rashmi Sarkar and her team that has made this possible and that has given us all the support to be able to create these two panel discussions today on two very important topics for discussion. So our journey on in the space of psoriasis started around 8 months back when we felt that there was very little representation of the patient voice in global forums. And we looked around, and when we searched for patient groups, then we found that very small informal groups existed, but there was no credible, strong patient voice that was working in this particular area. We were also looking at how psoriasis could be included into the National Health Policy and other schemes, including the NCD program at the national level. And we found that dermatological conditions were not really represented there. And that started us off on the journey of getting the patient voice and the psoriasis voice to the policy table. We've had a couple of events in the past, and we are now into our third national event, which will commemorate the global psoriasis or the World Psoriasis Day today. The actual day is tomorrow, but we are doing this today because of the availability of all the panelists. So thank you again to all the panelists for agreeing to join us today, and thank you to the audience for joining us to discuss some of the important issues that could shape the way forward for psoriasis treatment and access to diagnostics in the context of India. Our first panel discussion has eminent doctors from across the country and will be chaired by Dr. Rashmi Sarkar, who is the president of the IADVL, and she will be speaking briefly about why do we commemorate World Psoriasis Day, what is the introduction to this year's theme, and the need to prioritize psoriasis under the National Health Policy. This is her slide for introduction, and I think most of you would know her very well, but she has been elected president in 2022, and she's also the founder chair, Pigmentary Disorders Society and Indian Women's Dermatological Association. She's the editor-in-chief of Pigment International, co-editor of the Asian Journal Pediatric Dermatology. She has edited many books and is on the editorial board of 5 national journals. She has several international positions and the chair of the International Mentorship Committee of the ISD. She is also the board of directors, Asian Society Pediatric Dermatology and Women's Dermatological Society 2011 to 2018, and Skin of Color Society 2012 to 2015. She also has several awards to her credit and is a well-known author and a teacher and also a clinician. So a great warm welcome to you, Dr. Sarkar, and I hand over the position to you to chair the first session.
Thank you. Thank you so much. Yeah. So thank you so much, Dr. Ratna Devi. And truly, I think I'm very honored and very happy to be, part of this initiative, because I think we don't have so many of these patient advocacy groups. And it's definitely the need of the hour. So I was so glad to know that, we were trying to do something which does not exist in plenty, but maybe this is the way forward, in order to make policies. And I'm glad that, that is the topic, for the first panel. So I think I'm going to, without much delay, first, let me just introduce very briefly the 3 speakers of my panel. Then, of course, I will also take you through my talk. So we have 3 very eminent speakers in my panel, because my panel is recognizing the psoriasis under India's national health policy, right? So the first person is going to be Dr. Vibhu Vendiretta, who's going to be speaking on awareness, stigma, and quality of life of psoriasis patient. Well, she is the head and director professor, Department of Dermatology, Lady Hardinge Medical College, and associated SSK and Kanavati Saran Children's Hospital, New Delhi, India. And she's, out of her achievement, she's been a Commonwealth Fellow of Pediatric Dermatology at Gosh, London, Developing Country Dermatologist Award, which she has got from the Society of Pediatric Dermatology, USA, and has been an ICMR Fellow of Pediatric Dermatology at the Sick Kids Hospital, Toronto. She's been the founder secretary of the Society for Pediatric Dermatology in Delhi. and president of IITville Delhi State Branch 2011. Of course, she's got several other awards and accolades with a research interest, chiefly in pediatric dermatology and hair disorders. Can I have the next slide? Well, the next eminent speaker again is none other than Dr. Ramesh Bhatt, and he's going to speak on access to care, affordability and early diagnosis, inclusion of drugs under the national list of essential medicines, because I think that's a very important thing. And he's the vice dean of Father Muller Medical College, Kankanadi, Mangalore. He's also a director on ILDS, and he happens to be a past president of IITville. He's also been an honorary general secretary of the IITville and a WHO expert on neglected tropical disease. He's also got many awards, out of which one is the Dr. Ellen Sinha Memorial National Award from IITville, IITville Fulford Oration. Then, of course, Professor R. Shivakumar Memorial Award from Erode, Cuticon 2009, and Professor Ratan Singh National Award, amongst other awards that he has received. He has several publications, almost 138, and has contributed many chapters to books and also to research and clinical trials. So I'll go over to our last eminent speaker. And can I have the next slide, please? And that's none other than Dr. Ratna Devi. And she's going to speak on legislative and healthcare system changes to meet the needs of psoriasis patients in India. And of course, she's a patient advocate of Dakshama Health, which is helping us to conduct, this wonderful webinar. She's a medical graduate with Masters in Business Administration and has a deep passion in health system strengthening, especially with patient co-creation and co-production, and has over 31 years of experience in program management, strategy and policy development, healthcare system strengthening and advocacy. She's very passionate about patient empowerment and inclusion and works in India as well as globally to drive this agenda as the chair of the International Alliance of Patient Organization, also known as IAPO. Founding board member of APARTO, CEO Dakshama Health and Director Patient Academy for Innovation and Research, that is PAIR, out of the many hats that she wears. Of course, she's authored many papers on patient journey, and I think she's the force in bringing about, programs of this kind. So with that, we are going to definitely have an interesting panel. Stay tuned for that. So now I'll go back and I'll speak a little bit. I'll just set the tone, for this particular panel and speak on World Psoriasis Day, introduction to the 2022 theme, and need to prioritize psoriasis under India's national health policy. I think that is something very important. So can I please have my slides? So first of all, Babita, first of all, our theme today is Uniting for Action, Building a Voice for Psoriasis Patients in India. Can I have the next slide? Yes. So first of all, we do observe certain days for different skin disorders. And why do we have the World Psoriasis Day 2022, which is supposed to be on 29th of October? Well, this day is observed to raise awareness about the disease, which affects nearly 125 million people worldwide. In India itself, this condition affects 0.44 to 2.8% of the population, which may look like a small number, but let me tell you that this plays a big role in mental stress and mental health of the patient. So rightfully, this time, the theme of the World Psoriasis Day is mental health and psoriasis. Now, there is definitely very little understanding of the disease's symptoms, causes, and treatments. And because of this lack of recognition, both clinical as well as non-clinical sections struggle to manage the disease. Now, the symptoms are related definitely to one's skin, but it results in a slew of social stigmas and discrimination because it's on the very visible part of the body. And these are red-looking, plaques which are there, which are also scaly. and nobody likes having them, especially areas which are visible, the hands, the feet, because whenever, if you go for something like a job interview or something, you would not like to be seen around with that kind of a hand or any other part of the body. Unfortunately, there is currently no treatment that offers hope for a full recovery from psoriasis. Yes, it is a chronic disease and treatment has to be kept on. So the theme of the World Psoriasis Day, as shown in this poster, is mental health. And united, we unload the burden of psoriatic disease. I think that should be the agenda behind, doing all these programs. And psoriasis is heavy. It is heavy on our minds, on our body. It's time to put down the mental burden. Next, please. Let's have a look at the India-specific challenges in the management of rare diseases, especially psoriasis. Well, first of all, lack of awareness. What is it? Is it just leprosy? Is it an infectious disease, to the common public? Lack of infrastructure, prohibitive cost. Yes, there are medicines, but we know that most of us may not be able to afford it. Lack of knowledge, comorbid conditions. It's not just a skin deep disease. Lack of available or accessible diagnostic tests, misdiagnosis, cultural influences, lack of funding into establishing infrastructure in public hospitals or teaching institutes, competing with other dermatologic specialties like cosmetic dermatology, because as we know, cosmetic dermatology is something which seems to be a first priority for a lot of younger people, but it is these chronic diseases which are very important, right? Yeah, somebody I could read, it popped out in the box that it's not a rare disease. Although it is not a rare disease, the percentage, of 2% seems to be small, but I said that it has an enormous, importance because of the stress on our minds and on our bodies. That is why it's clubbed together with the rare diseases. So it is necessary to prioritize psoriasis under India's national health policy. It is definitely necessary to do so. And as I said, it's not just a skin disease. All of us know that it's a lot more. So first of all, the stigma and the discrimination. I've had patients, coming to me across, the borders of India. Sometimes they are ready to spend any amount of money, come and see a person, even in India, to do something with their skin disease. Loss of productivity, especially the joint disease that we have, the arthropathy, that can be very incapacitating. Lifelong management, association with comorbidities, a social burden, impacts one physically and mentally. There are many issues. The entire family is burdened. There could be marriage issues, the quality of life, and so on. Next, please. Strategies and approach for inclusion, what are they? First of all, there should be more awareness campaigns. We need to also build more research and evidence on psoriasis, because that is one area where more work is definitely needs to be prioritized. Build patient voice and champions to drive change. Liaison with research institutes, patient organization, etc. And create new treatments that focus on the disease's causes. Yes, there are a lot of new treatments. Some are not available all the time. So we do need to innovate all the time. Next, please. Now, this is from one of the papers by Dr. Rajgopalan, that from a dermatologist perspective, the key need gaps to be covered in the region are counseling skills, which can contribute to better treatment and compliance. Although cost is an important factor in decision-making, it is imperative to share all the options with the patients to ensure a shared decision-making between the dermatologist and the patient. So definitely more time for counseling. It goes a long way. Next, please. Now, what are the benefits of inclusion in, the government policy? Increase accessibility. This will ensure that other benefits like inclusion under universal health coverage schemes, because there are so many, medicines which have come up like biologicals and others, if they're well covered. Affordability of the treatment is another issue, and this will also leverage more research. There is research, but more quality research, which is aimed, on the mechanisms of psoriasis. It overcomes stigma and discrimination. This is important because dignity and respect of the patient is very important. Patient has to live confidently. As I said, it should improve the quality of life and reduce overall the social burden. Next, please. So this is just to set the tone of the rest of the discussions which are going to come up, because there are a whole 3 talks, which will talk about it. I thank you for your patient hearing. And we will go over to the next speaker, which is Dr. Vibhu Mendiretta. The only issue is that I might temporarily, leave, and then I will log in through my phone, because I will be in transit now, right? Because I move out at this point of time. So, but I'm there. I will be there on the phone. So the next speaker is going to be Dr. Vibhu Mendiretta, and she's going to be speaking, about the disease, right?
Good evening, everyone. And at the outset, I compliment the NGO, Dakshama, for taking up this cause of psoriasis and the psoriasis patient, and for putting up a unified action for creating a voice for our patients of psoriasis in our country. We know that psoriasis is a chronic disease, skin disease primarily, apparently to most of us, which causes a great deal of economic burden and a social burden. The reason why we are here and why we are talking about this disease is that we want on this particular day, that is the October 29th, to create awareness about this disease, since it was felt that the disease has not been given its due attention, and keeping in mind the global figures, the figures in our country, and the very little that has been offered to the patients from the various government agencies and from the side of the various national as well as international health agencies. Now, any disease can be treated successfully with a united effort. So there has to be a combination of balanced policies, which should be patient-oriented policies. There should be media coverage, there should be awareness programs, and the government should try to introduce certain health packages for the benefit of these patients of psoriasis who continue to suffer from this disease all their life. Now, what are the various ways to treat psoriasis? On this day, World Psoriasis Day, I would like to simply tell my patients that treatment, medical treatment, is one major pillar of making their disease better, which is with the help of either topical ointments, creams, then we have other modalities like phototherapy, light therapy. But other than that, holistic care of psoriasis is very important, and in that comes the importance of managing the stress levels of these patients of psoriasis. It is important that they undertake activities like yoga, meditation in order to keep themselves mentally de-stressed. They must always consult a qualified dermatologist for the treatment of their disease in order to curtail the complications, in order to keep their disease checked so that they can lead a happy, contented life. Their diet has to be balanced, especially vitamin D intake is very good for psoriasis, sun exposure is very good, and as a thumb rule, I advise my patients that they need to take care of their skin in a very special manner, and that is by applying softening agents, moisturizers for keeping the skin hydrated, moisturized, because dry skin is prone to itching, and itch and scratch can induce psoriasis. So now let us just see what are the perceptions of patients of psoriasis regarding their disease. On the basis of results of a survey which was conducted on these patients of psoriasis, it was seen that still many of these patients, about 10% of the patients still believe that psoriasis is contagious. Only 50% would have the knowledge that the disease is treatable. Rest 50% feel that there is no treatment for this disease and they do not seek any treatment. Psoriasis is very burdensome, not only for the patients who are affected, but also for their families also, which is quite understandable because the entire family bears the cost, the mental cost and the physical impact of the disease in terms of the expenditure and the upsetting of the lifestyle and the harmony of the life. So in nutshell, people with psoriasis, they are definitely at a disadvantage and they find their disease disgusting and they treat themselves as untouchables because they feel that there is a stigma still in the society about the disease and they are made to feel so by their friends, the other society members outside world. They have a very low esteem and they're not willing to enter into any relationship. So public also feels that psoriasis needs to be given due care and the psoriatic patients, they must be taking good care of themselves in order to find a place for themselves, an equal place, an equal footage in the society. It has also been seen that sadly in our country there are different systems of medicine which are available. Some are good, some are effective, but many a times due to lack of awareness about the disease and its triggers and its various causative factors, these patients they tend to delay consulting a dermatologist and there is about delay of about 8 to 9 months before they seek treatment and about 30% of these patients still rely on home remedies and they do not complete the treatment. They are not compliant to the treatment that they have been advised and 50% they show dissatisfaction with the treatment and majority still feel that the disease severely impacts their life. So as we know that psoriasis has got a number of myths surrounding it and let me just analyze various myths that surround this disease and myth number one is that psoriasis is contagious. Now, many of our patients, even in the urban areas, would still have a doubt in their mind that is this disease contagious? Because anything which is on the skin, any patch, any redness, which is chronic in nature, definitely raises a suspicion in the mind of the patient. But the answer to this is a resounding no, that the disease is absolutely, it cannot be spread from the patient to any other person merely by touching of the skin. So this awareness is the foremost which needs to be created not only for the patients but also in the society. Now, is it just a skin condition? So most of us would not really, or even the health authorities would simply think that it's a skin disease. It's simply not life-threatening. So it's just a cosmetic thing. So let us just not give much attention to it as long as it's purely in the skin and it is not going to affect the lifespan of the patient or curtail the lifespan of the patient. But this is, I think, the greatest and the darkest myth regarding this disease which needs to be busted by the treating physicians for the patients and for the society. The disease simply does not start and end with the skin. The disease, it is an autoimmune skin condition, and these patches, they can impact the various organ systems. Foremost amongst them are the joints, the eyes, the gut, and the heart. So all these long-term consequences of the disease can make psoriasis a very serious disease. Can we treat psoriasis with medications alone, like any other skin disease? So normally, when we treat psoriasis, these patients will be given a couple of ointments, creams to apply regularly of various kinds to give them symptomatic relief from itching and swelling. But the bottom line is that they need to use a moisturizer to keep their skin well hydrated. In case the patients do not respond to these creams, we have fortunately a wide armamentarium for treating psoriasis, and we have light therapy and we have oral drugs which can bring down the inflammation to quite a low level. So we have other modalities, but the fact is that treatment of psoriasis needs holistic care, and there are certain strategies or certain instructions which need to be given to the patients in order to achieve an optimum control of the disease, and that is that the patients must at all cost maintain a healthy lifestyle, which is the most crucial component of the treatment, by doing plenty of exercise, having nutritious meals, quitting smoking, reducing stress levels. Now, the next myth is that psoriasis is curable. Many of the therapies which are prevalent in India or even otherwise, quackery is very common. So they would promise the patients that it is absolutely curable. We are going to drive this disease out of your system. So they are cheated just by making, on the pretext of these false promises. But psoriasis, unfortunately, at this point of time, there is no cure for psoriasis. Dermatologist can help you find the best possible treatment for your psoriasis, which can keep you going and which can give you a good quality of life, and treatment options can certainly help you. Now, some of the authorities or some patients and some bodies feel that severity is only by the area involved by psoriasis, but it is not so. Now, for any skin disease which is on the cosmetically important parts of the body, such as the face, the genital areas, the palms and soles, or the nails, even though the involvement may not be affecting a large body surface area, but mere location on these cosmetically important areas can really impact the mind of the patient very adversely. So, such a psoriasis is counted as moderate or severe psoriasis, despite of the fact that it is over a very small body area. In our country, if we examine the treatment scenario, we have many pathies coexisting. We have Ayurveda, we have Unani system, and many of these systems would vouch for curing psoriasis. But whether we have scientific evidence for all these therapies, it is yet to be examined, it is yet to be documented. But definitely some of these therapies can give you symptomatic relief. But I would like to make my patients aware of the fact that some of the treatments can be having some toxic effects, and we need to treat psoriasis as a systemic disease, as a disease which is a disease of the internal organs also. So from that angle, it is imperative that these patients, they choose the right form of therapy, the safe form of therapy, which does not put them into and their life into danger of any kind. So after we have talked about the disease and its impact on quality of life, so there are certain important strategies which are related to the patient as to what the patients are supposed to do or learn about the disease. So number one thing is all the patients should be aware of what is the disease. This health education is very important, that the disease is not contagious, it is treatable, and this has to be achieved on the basis of planning, carrying out different public campaigns. Patients have to be given information on importance of stopping alcohol and tobacco intake. Psychotherapy is very important in case they are not able to get over their anxiety or their mental health issues, but they need to get in touch with a psychotherapist. They need to practice relaxation techniques. There should be support groups for these patients, and support groups can be very helpful because the patients can easily relate with the patients of the same disease, and they can relieve themselves of the doubts that they have about the disease. Now, at the same time, when it comes to treating psoriasis patient, the doctors, the physician relationship, patient-physician relationship comes under the focus, because the physician or the dermatologist needs to exhibit a friendly attitude at all times. The patients need to be extended an empathetic attitude. You should have a friendly, open relationship. You should be able to listen to the patient's apprehensions and the doubts, and you should be able to have a discussion where the patient can be taken on board regarding selection of the treatment, because eventually the cost has to be borne by the patient, since these drugs, very few patients have some medical insurance available for them. So it comes to selecting a treatment which is cost effective, which the patient's pocket can bear. So the patient has to be taken on board. The treatment should be efficacious, it should be safe, and patients need to be counseled about the importance of adhering to the treatment, because if you discontinue the treatment, the psoriasis can come back. And all this can be done by providing written instructions to these patients. Now, just to come to the concluding part of my talk, I would like to just simply tell my patients that it's not that all us, common people only suffer from psoriasis. Psoriasis, there are many celebrities who are living with psoriasis, and one such celebrity is Kim Kardashian, who was a very popular, famous TV star and a businesswoman, who has launched a special makeup line for just to show her, share her story of this autoimmune condition, where the cells grow so quickly and the skin looks so blotchy and so scaly and so red. So I'm sure that all our patients of psoriasis, they can be enabled to uh, deal with their disease in a more positive manner, in a more healthy manner, and in a more holistic manner. And at the same time, it is our duty to make the health authorities realize the importance and the extent of the disease in our country, and the necessary policies which should be brought out in place for the benefit of these patients who are battling with the challenges of psoriasis in one way or the other. I'm so very thankful to you, and now I hand over the proceedings to my colleagues. Thank you so much.
So thank you so much, Dr. Vibhu, for that very lucid talk. And now we move over to the next person. And the next person who will be speaking now will be Dr. Ramesh Bhatt. He's going to be throwing more light as one of the panelists. Over to you, Dr. Ramesh Bhatt.
Yeah, good afternoon. Thank you all. So I will share the screen. So I will be mainly talking about access to care, affordability, and early diagnosis in psoriasis and inclusion of drugs under the National List of Essential Medicines, especially the drugs that are used in the treatment like psoriasis. Of course, psoriasis is a very chronic disease and with sometimes exacerbations, and sometimes we can give complete cure many a times, and the prevalence varies and maybe directly related to lifestyle changes also and the environmental factors. And in countries like India, the prevalence is increasing as we are going from developing country to developed countries. So psoriasis not just affects the skin, but even the joint deformities may be sometimes really difficult for the patients to lead their day-to-day life. And there is a nail abnormality of also in psoriasis. Nearly 40% of the patients will have difficulty. And of course, the quality of life gets affected, and it causes great physical and emotional and social burden. And as the theme of this year's Psoriasis Day is related to mental health, and we do see quite a good number of patients going for depression. And it is very important to give a holistic treatment for patients. It is not just the drugs and not just the cure of their cutaneous conditions, but also the psychological support by the doctors and the family and the society. That is very important. And already many things have been told about psoriasis as a metabolic disease, and many of the patients do have cardiac problems. And then, of course, psychological one we have already discussed. And it has got some effect on our day-to-day life also. For example, consumption of alcohol, smoking, all these will sometimes increase the severity of psoriasis in patients who are already suffering from that. So as I've already told, it not only affects the skin, but sometimes very severely the joints. And we have the psoriasis epidemiological screening tool that is both for skin as well as for the joints. Then coming to the access to care, affordability, and early diagnosis in psoriasis. So because there is affection of physical health and mental health strains, the economic impact is also quite important. The awareness of psoriasis is not very high, especially in countries like India or the countries which has got less number of doctors. In fact, I was told in Africa, there is only one dermatologist for a million. So that is the disturbing factor as far as the dermatologist is to the patient ratio is concerned. And many times the psoriasis is misdiagnosed to other conditions like fungal infections, or sometimes there may be combination of both psoriasis and fungal infection, that what we see sometimes nowadays. And World Health Organization has told that it passed a resolution that burden of psoriasis, and it is committed to increase their efforts to fight the stigma and unnecessary exclusion of people living with psoriasis. They recognize as well as that too many people in the world suffer needlessly from psoriasis due to incorrect or delayed diagnosis, inadequate treatment options, and insufficient access to care. So the resolution requested World Health Organization to prepare a global report on psoriasis, drawing attention to the public health impact of psoriasis. So this was the global burden of the disease in 2010. And the access to care, as I've already told, dermatologists, most of the time, they are not available everywhere. So it is mainly concentrated in big cities. It is true for India also. We have plenty of dermatologists in metros, in capital cities of the states, and even sometimes even the district headquarters, but not in other areas. So all patients who are suffering from psoriasis do not get the quality of care that is required. Care for patients with psoriasis requires more than management of skin lesions and joint involvement. So the complexity of psoriasis means the prescribing drugs in isolation is insufficient, and as I already told, the holistic whole person approach to care is required. So it is necessary to rule out other associated problems, as I've already told, the metabolic disease, which includes hypertension, dyslipidemia, diabetes, and then the psychological problems, and the screening for other problems, and what are the other medications that they are receiving. That is also important, because many of the drugs that are given in psoriasis may have the drug interactions along with the other drugs. So this is a chart showing the roughly the algorithm how to go about regarding the comorbidity screening, and then the psoriasis arthritis screening, then co-medication screening, the triggering factors, and then how to go for the actual treatment. Many a times what happens is that patient may be having mild disease, but the lesions may be on the exposed areas, and if the patient is frequently moving around or in high level meetings, then it will be affecting his quality of life. Whereas in some patients, it may be extensive, but they may not be so much mentally disturbed about that. So these two things will have to be considered. It is not just the scoring of psoriasis lesions that is important, but what is the quality of life of that individual. So depending upon that, we will have to select the treatment. The barriers to quality care involves, one is low level of knowledge about skin diseases among non-dermatology trained health professionals. In fact, if you go to Ministry of Health, both in the state as well as the center, they just say, oh, psoriasis is just a scaling, that's all. So they do not understand what is the psychosocial impact of this disease, the high cost of treatment and limited access to health care. And as I already told, there may not be any dermatologists in the nearby area, especially in villages. Then patients sometimes feel that it is contagiousness of the condition, so that it is alleged contagiousness, which is not true. So that we have to be very, very particularly tell about this to the family members, that psoriasis is a non-contagious disease, and we can give almost a presumptive cure in many patients. Of course, they may have to take the medications continuously, but sometimes, as it has already been mentioned, there may be complete disappearance, but with sometimes the recurrences. So adherence to psoriasis treatment is a challenge, and a lack of adherence by many psoriasis patients can be a reason for suboptimal managements. So as I've already told, the WHO statistics is here. This is from 2015. Access to healthcare, especially for the modern healthcare, may not be available in every place. And then inadequate public funding. For example, in India, for health, we just spend around 2.5 to 3% of the total budget, which is probably not required. So if psoriasis has to be included in universal healthcare system, and then there should be increase in this health budget also. The self-funding of treatment sometimes may not be affordable for many patients. For example, many of the drugs that are available for psoriasis is very costly, and drugs like biologics may not be affordable by many, and our insurance schemes and the government schemes do not cover this. Then in many countries, most treatment for psoriasis are either unavailable or are not reimbursed, even those on the WHO model list of essential medicines. In fact, this one I can tell you is that ILDS has recommended WHO that biologics has to be included under essential medicines, which has been provisionally approved by WHO. So many European countries have included one biologic in the universal healthcare system. I think even in India that has to be done. So chronicity of psoriasis, expenses compound over the duration of the treatment, then high cost the cost of therapies for chronic conditions like psoriasis is a huge burden. Even in some of the developed countries where psoriasis is covered under insurance, the moment biologics are prescribed, the premium for the policy increases in the next year. That is also a burden many a times for the patients. Then cause for delay in diagnosis is hesitancy of treatment, then loss of work days, considering it is merely as a skin disease, social acceptance if diagnosed, all these are the problems. So the universal access to health service and essential medicines, so that can be helpful, and then patient needs and set appropriate goals related to the treatment. Then people-centered model of care, then standardized tool for diagnosis and treatment, the empowering patients and combating stigma and the education of the public. The national list of essential medication includes only coal tar, salicylic acid, betamethasone, then methotrexate, and cyclosporin and mycophenolate mofetil. ILDS has recommended WHO to include biologics under essential medicines. As I've already told, some countries have included biologics under universal healthcare. In fact, in 2018, when I met Niti Aayog member Dr. Vinod Paul, he told that the Ayushman Bharat can have package offers for patients, but the amount that was quoted was very low, so we didn't go forward. Of course, future talks are required with the ministry so that it can be included even under Ayushman Bharat. So the drugs which are not listed, mentioned here, biologics, and then even apremilast, acitretin, all these things are not included. And these are my references for the talk. And I thank Ratna Devi and Dakshama Foundation for giving me this opportunity. Thank you.
Thank you, sir. Probably I will take over now and speak as a third speaker to this presentation. And I'm really grateful that you set the context so beautifully, because it gives me the background to talk about why it is necessary to have some kind of a legislation. So my topic today is legislative and healthcare system changes to meet the needs of psoriasis patients in India. And I will be covering this in three sets, which is the brief background. Most of it has already been covered by Professor Ramesh Bhatt. What is the current scenario and the way forward? So legislative examples, as Professor Bhatt has already highlighted, in 2014, the 7th World Health Assembly recognized psoriasis as a serious non-communicable disease. And it sort of told the member states through the resolution that psoriasis is a chronic, non-communicable, painful, disfiguring, and disabling disease for which there is no cure, and acknowledged the psychological and social burden of the disease, and that many people with psoriasis suffer due to lack of awareness and access to sufficient treatment. And then this led the way, as Dr. Bhatt said, to the Global Psoriasis Report, which was published in 2016. There is also an act called the Psoriasis and the Psoriatic Arthritis Research Cure and Care Act of 2011, which was admitted to the US Congress in the 112th session. It is still awaiting approval, but there are discussions around it. However, individual states in the US like North Carolina, Washington, Wisconsin, etc., have laws enhancing access to modern treatments through something called a step therapy, where they can bypass the treatments that have not been proven to be beneficial to patients with severe disease condition, and they can have direct access to modern biologics without actually going through the preliminary steps of treatment. The Philippines passed a psoriasis bill in 2021 that was approved, and this provides for comprehensive care for patients with psoriasis. It also mandates that all patients with psoriasis have appropriate access to not only diagnosis and treatment, but also a care continuum pathway. Some European countries like Germany have care acts for psoriasis, and this has been made possible through professional associations who felt that psoriasis could be extremely debilitating if not diagnosed early and managed for life. So again, Dr. Bhatt referred to the global report on psoriasis by WHO. And the important fact is, though it does have India mentioned in it, there is no data that has been referred to due to lack of credible data and studies available from India. Whatever is available is patchy. And then the available prevalence data came from only 20 countries, meaning there is huge geographic gaps in knowledge, especially from low and middle income settings. And between 2016 to 2022, not much has changed around psoriasis epidemiological data or research studies that can give credible information about the life course of the disease or the natural history of the disease in the context of India. So some of the actions for governments and policymakers that were recommended through the resolution as well as through the global psoriasis report was to ensure that people suffering from psoriasis have access to professional medical care. And this is a qualified dermatologist who's trained on treating chronic dermatological conditions. Essential that psoriasis is diagnosed as early as possible to prevent early onset of other complications. Patients suffering from psoriasis should have access to comprehensive, individually adapted treatments, which is people-centered, as Dr. Bhatt mentioned. Shifting to a model of people-centered and integrated health services is outlined in the WHO Global Strategy on People-Centered and Integrated Health Services. And when I talk of integrated health services, because there is multiple specialities involved in it, it is a team effort that is required, and that may not be possible when patients are accessing a single specialty, especially as outdoor patients and not being admitted, or they come sporadically only when they have a problem. Then it becomes very, very difficult to have integrated care pathways designed for them. And our country also does not have guidelines for integrated care pathways for dermatological conditions, especially psoriasis. So how can we move ahead on this? And then, of course, support research. We do not have independent governmental support for research. Reduce the stigma and discrimination. So how do we have social programs that can increase awareness, have rehabilitation, and maybe legislative policies through which patients with psoriasis are not discriminated in their workplace, and rehabilitation and employment, as I said. So why do we need legislation? Again, we know that this is a multi-speciality disease that has got many comorbidities and needs a team approach. We do have in India a program called the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, and Stroke. Very recently, about a few years back, we also included mental health and COPD into this. However, dermatological conditions are still missing in this dialogue. And as Dr. Bhatt pointed out, neither at the national level nor at the state level, there is much awareness on why this should be included and what kind of care pathways have to be designed so that there are some operational guidelines that are made available to the implementing agencies. We also have a national multi-sectoral action plan for prevention and control of common non-communicable diseases. And this speaks more about cardiovascular diseases, hypertension, and oncology, and the care continuum pathways for how to manage this, especially the triggers and risk factors. We do know that alcohol is a common risk factor for most cardiac diseases as well as psoriasis. However, no mention of psoriasis is there. It's more about cardiovascular diseases and cancers. So how do we include psoriasis into this national guidelines and policies that already exist? That is what we need to aim and work for. Again, as referred to, there is a model treatment guideline by WHO, and most of it is already included into the standard treatment workflows by ICMR that was recently published in its volume 3 in 2022. However, biologics are just mentioned as those that could be made available for resistant cases. The cost of treatment is too high for most patients to be able to afford it. And both within WHO as well as in ICMR guidelines, I think biologics need to be included as something that is made readily available. As far as health system strengthening is concerned, already my previous two speakers have spoken about why it is important to not consider it as a single specialty, but as something that has a care continuum pathway. There is not only lack of awareness amongst common people, but the first point of contact for most dermatological conditions is a common, maybe a family physician or somebody across the street. And many of these doctors are not aware about psoriasis. They cannot differentiate between the various chronic skin conditions and confuse between, say, atopic dermatitis or psoriasis. And therefore, the referrals become delayed, and the cost of treatment as well as the management becomes more complicated. So how can we make primary care physicians and primary healthcare doctors aware of this condition so that there is early referral and good management? We have a lack of standardized tools for diagnosis and treatment. Yes, there are guidelines, but most physicians do not use it due to lack of time and lack of resources. So how can we make that something that is used by most of the physicians before they do a clinical diagnosis and set the treatment protocols? And of course, the cost and availability of essential medicines has already been discussed. There's lack of awareness amongst patients and caregivers and delay in reaching a qualified medical professional. Again, through our work with patient groups, we have realized that most patients try to access alternate medical treatments, and it is only when those treatments don't work or they have adverse effects that they go to a qualified medical professional. And we do not have any guidelines for care continuum pathways and integrated health systems. So people participation and lived experience, as you can see, I was the chair of a WHO informal consultation with people living with non-communicable diseases in February this year. This was for the Southeast Asia region, and this was preceded by two global consultations where people who had chronic conditions, non-communicable chronic conditions, were invited to speak about what they felt needed strengthening within health systems and policy. And we had representation from a host of specialities, but sadly, especially in the context of Southeast Asia, we did not have a single voice from dermatological disorders. I think this needs to be corrected, because unless there is a representation, the voice will never be heard. And that is one of the reasons why we are trying to create the patient advocates as well as a strong patient group, because not only will they work in the context of our country, but are able to participate in these kind of consultations. About a month back in August, we had a consultation, as you can see, where we talked about integrating HIV and Hep C into the national NCD program, and how do we bring the learnings from both these programs to strengthen each other. So these kind of dialogues are already happening in other specialties. However, they have still not sort of taken the precedence or the importance in dermatological conditions. And I think it is time that we started to work on these areas as well and highlight the issue. Earlier this year, we had two roundtables, and this was to create awareness not only amongst the policymakers, but also in the region. As you see, the first one was on the occasion of World Rare Disease Day, and we had representation from SOR Philippines and SOR Asia, as well as from the rare disease of the Southeast Asia region, which is a PARDO, and the doctors from not only from India, from Ministry of Health, but also from clinicians from AIIMS and other institutions. And the discussion centered around how can we make access to treatment better. The second roundtable was more around how do we create patient registries, etc. So as a patient organization, we are trying our best to increase awareness, not only amongst policymakers and physicians, clinicians, and physician associations, but also amongst patients and patient groups and general public. So what could be the way forward? One of the things that needs to be worked on is strengthening the patient voice. How can we make a credible patient group with the right kind of patient advocates who can then be trained to speak at various forums? Creating an advocacy agenda and driving it from all fronts, increasing awareness through outreach activities, which we are already doing, but when we work together as partners, and the more the partners, the better the outreach. And reaching out to policymakers at national and state level. We already done some work at the national level. We plan to do some work at state level as well. and we'll seek your assistance in reaching out to state level authorities and working on a care continuum pathway which is inclusive of palliative care. And that is an important part of it, because most of the patients who end up with arthritis are disabled, and they do not get the benefits of the Disability Act. So how can we increase awareness so that people who end up being disabled or are unable to take care of themselves are included into other programs so that they get the benefits from these schemes as well as programs. And I'll end here because we are already over time. Thank you so much for giving me your attention.
Thank you so much, Dr. Ratna Devi. That was absolutely precise. And actually, do we have time for questions and answers? Because reason is that our discussion, we are running pretty much late. Should we just take up one maybe, for discussion? So we've been talking about, patients and patients advocacy. Do you think there is a system, building up patients' rights, the psoriasis patient rights? Maybe Dr. Ratna Devi or Dr. Ramesh Bhatt, one of you could, take up this, address this question.
I think Ratna should be in a good position to answer this. Yeah.
So thank you, sir, and thank you, ma'am, for this question. I will just briefly say that we do have global associations like the Global Skin and IFPA that are doing a lot of wonderful advocacy work. And they do have memberships from across the region. Because we do not have a patient organization in India that can be a member of these global associations, there hasn't been much that has been highlighted in the context of India. And that is the reason why we are building this patient voice. And once this voice is built, our experience is that once the voice is built, then they start their own advocacy work. And we have good people who can speak on behalf of these patient groups. They need a little bit of training to be able to voice their demands well and in the right context to policymakers. And that is a journey that we have just begun. We hope to be getting your support to identify more such people who are willing to join this patient organization.
Yeah, that's exactly what we are looking forward to also. And that's why when you asked that whether IDPL can help, we thought, yeah, it's a win-win situation that we do need to, work more with patient-centric groups. That is one thing. Do you think that there should be, a better referral system actually for the psoriasis patients? What do you feel about it?
Yes, ma'am, because as I said, when we speak to patients, most of them access a general physician who usually has no clue. So they do symptomatic treatment based on what is visible to them, but not through a clinical diagnosis using the tools that Dr. Ramesh Bhatt mentioned, because they're not trained on it. And most of them do not refer. So I think there needs to be awareness amongst primary physicians and general practitioners on what psoriasis is and why an earlier referral is extremely important, so that the complications don't set in. Did we lose Dr.
Dr. Rashmi, you're on mute.
Yeah, sorry.
Yeah, unmute.
Can you hear me now? Yeah.
Yeah.
Okay. So I said, as you said, this is the beginning and this is in the right direction. So because we do lack, these patient advocacy groups. We're just back from the ILDS, Skin Summit in Peru. Dr. Ramesh Bhatt was also there. He's one of the directors there. And we did talk about, these patient advocacy groups. So I was really glad that we are doing something, in that right direction. At least we are, with the times, and this is something that we should take forward maybe in the next couple of years also. It's not just a year's project, it's got to be more than that. So with that, I think, because we do not have more time, we are already running behind schedule. Let's get on with the discussion, the next session, and maybe we can come back and revisit this once again, right?
Thank you, ma'am.
So,
thank you.
One minute, Rashmi. Actually, yes. I'm in touch with Jennifer Austin of IADPO. She knows very well about Dr. Ratna Devi. And
yeah, she knows.
Yeah.
You're
We have
very famous.
already included two vitiligo support groups, and our recently initiated psoriasis group also I have recommended. I think Tamanna or Dr. Ratna Devi may receive mail from them very soon. Yeah.
Yeah, she's
Yes, sir.
aware actually of, Dr. Ratna Devi. That was the best part, that she knew the name and she was aware. So I think we're doing it in the right direction. So with that, I'd like to thank, Dr. Vibhu Vendiretta, Dr. Ramesh Bhatt, as well as Dr. Ratna Devi for the session. I think, Tamanna, maybe you can take it forward. The next session is going to be moderated by Dr. Sunil Dogra. So thank you so much once again. And from IIT, definitely we will support whatever much we can do.
Thank you, ma'am. Thank you. That is
Thank you
really very
all. Yeah.
welcome. And our second session or second panel is bringing the psoriasis patient voice to the policy table, and will be chaired by Dr. Sunil Dogra. So if I can have the introductory slide for Dr. Dogra. So Dr. Dogra is a professor at PGI Chandigarh, and he has several awards, honors, and achievements to his credit. He is the editor emeritus Indian Dermatology Online Journal and a chairperson of Pigmentary Disorders Society Academy. He's a past vice president, Indian Association of Nephrologists, and has won several awards. He's the president, Hereditary Angioedema Society of India, and his special areas of interest are psoriasis, clinical dermatology, and leprosy. Over to you, sir, to chair this panel.
Thank you, Dr. Ratna Devi, for this kind introduction. And I welcome all the delegates for this session too. The theme is bringing the psoriasis patient voice to the policy table. So in this session, we have an eminent speaker with us. Tamanna, can we have the CV slide? We have Dr. Rashmi Kumari with us. She is professor and head of department at the dermatology department at JIPMER Pondicherry. She has been working in psoriasis, including ICMR project and some clinical trials. And she's also assistant editor, past assistant editor in our Indian Journal of Dermatology. Next, we have Dr. Vishalakshi Vishwanath. She is professor and head of Department of Dermatology, Rajiv Gandhi Medical College at Thane. She is chief editor of journal and on editorial board of several journals. She has numerous publications, and apart from various areas of her interest, psoriasis is one of them. And next we have Mr. Varun with us. He is a young graduate who has psoriasis since childhood. He has been facing it very boldly and has performed very well in his life, and now into professional business life. So I think we'll be hearing about his experience and how he has coped with the disease. Thank you. So just setting the context about this session, we know, as we heard from the previous speakers, that psoriasis is quite common in our population. Perhaps most of the cases are now detected, and the prevalence varies from about 0.1 to 10% in various countries. And it's estimated that there are about 100 million individuals who are affected with psoriasis worldwide. Dr. Ratna Devi and Dr. Ramesh Bhatt had discussed in detail about the WHO resolution on psoriasis as a non-communicable disease. So this particular report, it emphasizes various action agendas for the state member countries, and for the benefit of the delegates who may have joined late and for the attention of the policymakers who are on this webinar, I would like to highlight few of these recommendations, which are very important, that member states should ensure that people who are suffering from psoriasis have access to professional medical care and comprehensive individually adapted treatment, as the optimum treatment will improve their mental health and will also reduce the societal cost of the disease. They should have at least minimum access to the WHO model list of essential medicines, including systemic therapies. There should be provision of universal health coverage schemes covering the cost of these treatments. For newer biologics and biosimilar therapies, more needs to be done in addition to reducing the price of these medicines whenever possible. And government should take cost effectiveness of the treatment options into account when making national treatment guidelines for psoriasis. So therefore, government and NGOs and patient advocacy group like Dakshma Healthcare, they have a key role to play in reducing stigma and discrimination in psoriasis, as it's the society, not the psoriasis, which causes exclusion and discrimination of the patients who are suffering with psoriasis. So this situation can change through campaigns to raise awareness on psoriasis in the population, in the community, among healthcare professionals, as we are discussing it today, and also by even implementing the new legislations against the discrimination of these patients in the workplace and in the society. So without taking much time, as we are running behind the schedule, I would like to invite the first speaker of this session, Dr. Rashmi Kumari. She'll be speaking on investing in research and natural history, patient registries. So Dr. Rashmi, please.
Sir, is my screen visible, sir?
Yes, please.
Thank you. So my topic is to talk about the investment in psoriasis research and to talk about patient registries. So going on to this, what are the topics in research? Regarding clinical research, I will be telling about some points and the need of registries. So cost benefit analysis of interventions is very minimal in India. And what we have realized that even though some of the drugs are easily available in government hospitals, there is a PGI study which has told that the cost of systemic therapy for moderate to severe psoriasis above 10,000 and more than 10% of the earnings of the family. So that cost benefit analysis has to be done. Regarding quality of life and economic loss to patients, we are all as dermatologists well aware about this topic, and we know there have been enough studies in past, but very few recent studies are there regarding newer treatment options that are available. And recently, many new drugs have come into the market apart from the standard options of the topical therapies, which Ramesh Bhatt sir has told, and the systemic therapies, which are commonly the first line being the methotrexate, cyclosporin, and acitretin, and the newer biologics. In addition to the newer biologics, for moderate psoriasis, mild to moderate, there is apremilast, and some people have also started advocating the use of tofacitinib. But the data regarding how effective these are and when they are to be used is very less. Also, there is a guideline from one of our Indian dermatologist colleague who has told about when to use biologics, but since biologics are used in a small percentage of patients, so how each doctor has their personal experience with a very small number. So there is a need to collate all this data and quickly have more evidence scientifically of how and when to use the biologics. So this is a slide from the global psoriasis report, where they have actually told that the research points are in studying the epidemiology of psoriasis, understanding how the economic burden is there, recognizing the various comorbid disease, as already told about alcoholism and cardiovascular morbidity and mental diseases, which are commonly add to the burden of psoriasis as well as cost of treatment, and also improving early diagnosis. Also, I saw in the chat box there are some questions about misdiagnosis. So yes, in certain cases, especially early cases, sometimes there is difficulty in differentiating it from eczemas, and somebody has asked question regarding lichen planus also. So yes, more than that, I felt that apart from these three topics, we also need to recognize that this is a major non-communicable disease in India. And most dermatologists, if you ask them, psoriasis is one of the major disease which they handle in their outpatient department. But the problem is that the government has not accepted it, and it has not yet come as part of any of the insurance schemes, the Ayushman Bharat or the other schemes which exist, and even private insurances. So there have been few social studies and few behavioral studies, but the data is not sufficient enough to go to the government and ask them for providing economic support to these patients. More than 8 million patients are there, and I have known that Dr. Sunil Dogra's institute has done a thesis on cost analysis. So like this, many hospital-based analysis have been done. Some of them are published and are available in public domain, which we can use. But apart from that, we need to generate much more data in these areas. So regarding the evidence with the use of the new drugs, I have shown few studies which are existing regarding use of apremilast in the real world scenario. Especially now many people accept it as an adjuvant or as a single agent in mild to moderate psoriasis. And also this article from in IADWELL from the SIG Psoriasis Symposium, which tells about how to use the biologic use in Indians. So some data is already on board with us, but we need to have some more clinical as well as epidemiological data in this regard. This is an article by Dr. Thapa, who has clearly told what are the areas where we need further research. So one of them being pharmacogenomics, means we can have early diagnosis, some HLA detection, and some polymorphisms can tell us which drug a patient will not respond to or respond better. That will help us in choosing the systemic drugs better. Also, the advantage of doing research in this area of pharmacogenomics is we know that out of 100 patients that we treat, there is going to be a partial response in around 20 to 30% of them, and less than 20% are not going to respond at all. So if we know that, we need to have clear indicators who are such patients, or there should be a clear guideline for us that after 48 weeks or up to 6 months of giving the standard systemic therapy, if patient is not responding, then we have to go for alternatives like the newer biologicals. Newer drugs which are available easily abroad is simply because there are a lot of patient advocacy groups, and also a lot of drug companies are willing to invest their research and money into this area to bring new drugs which have bought drugs like ustekinumab, ixekizumab, risankizumab, which are already being used abroad. It is true that it is being provided as part of insurance schemes in many countries, but as some of the speakers already told, yes, at least one biologic has been made as part of their essential drug list as well. So this is just to show you the cost of biologics, which is in one of the studies from India, that it is huge. So for those patients who are not responding to the standard conventional systemic therapies, they need some help from the government. And if we have a collated data of what is the number of these patients, and that's when I come to the importance of awareness among the patients regarding these provisions in the government. Like we can use RAM scheme for certain, but this is not very well defined. None of the dermatological diseases come under the RAM scheme except if it is at the discretion of the director of the institute. And second thing is, in Ayushman Bharat, none of the skin diseases are there. In some of the state schemes, before erythroderma used to be there, but right now only pemphigus and connective tissue disorders like SLE and mixed connective tissue disorders are there. So if we could work on this area, that will help our patients a lot. importance of social research is also in bringing out influence of how these things affect the patient and how long it takes for a patient to respond and get to the right doctor. Networking between various regional care centers such as the state and the tertiary institutes will help us. This interaction will help us to have better drug development within India and promote research within India. So what we can do is, I think as Madam has told, Rashmi Sarkar ma'am has told, their expert group within IADL is ready to support the development of standard diagnostic and treatment guidelines within India and work with help of ICMR so that we can have better molecular diagnostic regarding HLA positivity as well as pharmacogenomics in relation to treatment of psoriasis. Coming to the registries, it is good that our government has already started the NDHM website where psoriasis is recognized, but the burden of disease is not yet estimated and we need to work in that area. The other suggestions we have as a dermatologist is to ICMR is willing to give grants for research on non-communicable disease, and psoriasis being one, we could do more in this area. As Dakshama has already started the work on patient advocacy group, maybe we could have, as she said, there are only small Facebook pages. YouTube is a very good method to have raising awareness and to give more information to our patients about the disease. And we could also get into discussion with drug companies so as to how we can reduce the cost of the drugs. As we know, rituximab, when it was introduced, it was almost 80,000, but with the introduction of biosimilars, and they work pretty well, the costs have come so much down up to 6,000 per injection. So that is a very good news, and government can also help us in bringing down the cost of these essential drugs for psoriasis in those who need it. So we have already heard about how we are on road to have a roadmap of how to go about this. Maybe the registry will help us a lot. And for this, all dermatologists have to come together, the state ones as well as the central one, so that we can have with COVID, we have already got a very good success story where we knew the COVID numbers in each state and national and overall in the world. So if the same could be done for psoriasis, that will be a great success story. And then we can present this to the policymakers so that they can help us to make the treatment available, both the costly ones as well as the newer ones, to our patients. So this is our role as a professional body. IADVL can help in standardizing treatment protocols, disseminate information both to our patients as well as to the policymakers. We have already heard that we should form better referral pathways so that those patients who are not responding to treatment can be referred to tertiary centers or centers where they can get newer drugs. Also, sometimes free drugs are available as part of clinical trials. Those drugs which are not yet approved but are in the making. So the referral pathways will also help our patients to have access to such drugs which are in clinical trials. Thank you.
Thank you, Dr. Rashmi, for your very precise, informative, and thought-provoking presentation. I agree with you that it has been almost 8 years since psoriasis was listed as a non-communicable disease by WHO, but it has not received its due importance by policymakers, healthcare systems, including insurance regulators in many countries, including India. And I think we all need to work collectively in this direction. Thank you once again. And now I invite Dr. Vishalakshi for her next presentation. Dr. Vishalakshi Vishwanath, please.
Can you see the slide, please?
Yes.
Okay, good evening, everyone. I thank Dakshama for inviting me for speaking on rare psoriatic disorders is enough being done. Now, why do we need to talk on rare psoriatic disorders when actually even psoriasis is not being addressed? But as we tell all our students and as medicos, we always like to delve more and have more knowledge and research into the rare forms, because that is what simplifies and helps to evolve therapeutic strategies for the simpler forms. And probably we will be able to catch the attention of the regulatory bodies and the policymakers when we discuss about rare disorders. So what is a rare disease? It is a disease as defined by not fewer than 200,000 people in the USA is considered. And has rare forms of psoriasis being included by NORD? Yes, there are 3 forms: pustular psoriasis, erythrodermic psoriasis, and psoriatic arthritis of the mutilans type. So, but where do we stand? In India also, we have an organization for rare diseases in India, where the rare variants of psoriasis have not been included. Recently, the Ministry of Health and Family Welfare has approved a national policy for rare diseases. And as an organization, I think we should aim to try to include at least some forms of psoriasis in this part so that we will be able to help our patients to access better care, especially those patients who are having a lot of resource constraints. Now, whenever we need to advocate to policymakers, we need to know the prevalence and pattern of psoriasis in India. So there have been a lot of studies, which I think has been told earlier also. The prevalence is about 0.5 to 2.5%. But if you consider the population of India, it's a huge population, even if a 2.5% is affected. And as Dr. Ramesh Bhatt stated earlier, the number of patients of psoriasis is probably increasing, maybe due to the lifestyle modifications, what we are seeing in our country with improved development and improved economic status. Now, regarding the rare forms, I mean, there's not much data on the prevalence of rare forms in India. The same is the status even in the developed countries. Like this is the published GPP data, which is highly variable. As you can see, it is from 1.76 to going above 88 in France, Japan, and Korea, the cases per million persons. Erythrodermic psoriasis has a high prevalence of about 1.25 to 2%. But I feel in India, we do get a lot of erythrodermic psoriasis patients because they account for majority of the hospitalizations of the psoriatic patients in India. Regarding psoriatic arthritis, this has been a good meta-analytical study which has been published, in which there is a high percentage of psoriatic arthritis. Probably as dermatologists, we are not diagnosing them adequately, or there has to be more multidisciplinary approach with the rheumatologist so that we are able to identify the psoriatic arthritis patients properly. If you see, there is even a high prevalence in the Asian population, and even the pediatric psoriatic arthritis has a high component of prevalence. Now, I always think the best way to influence the policymakers is through a patient story. So what Daksham has started with the patient advocacy would be very good. Now, as a clinician, when we encounter rare forms of psoriasis, it's a really tight rope walk. Now, this is a short case which I would be presenting. This was a 35-year-old male working in a bank, and he was suffering from psoriasis since nearly a decade. Presented to us this January, was on oral methotrexate, had extensive involvement, had episodes of methotrexate toxicity, and he was totally erythrodermic with pustular flare and arthritis when he presented to us, and was already on prednisolone, cyclosporin, and apremilast with very partial episodes of improvement. As you can see here, there's extensive involvement, formation of pustules, also arthritis along with nail involvement. Now, what to start this patient on? First, we had to taper off his steroids, which was difficult. And the options which were there with us, acitretin and cyclosporin, we couldn't continue cyclosporin for a long time, which is the magical drug actually for any form of severe psoriasis. It had to be discontinued because of deranged creat and electrolytes. And then we had to restart prednisolone for his low cortisol levels, partial improvement, but there was not much choice. And what we could do is secukinumab we could initiate, because at that point of time, we had secukinumab which was being shared by 3 patients. We had luckily, I mean, I must have approached the institution at least since the past 5 years. And with the help of the pharmaceutical companies, we could get about 30 vials of secukinumab for 1 year, which unfortunately the tender process is not going ahead in the next consecutive year. But luckily this patient could benefit the use of secukinumab, and you can see a clear improvement in his condition with total clearance. Currently, he's on a lower dose because of financial constraints along with apremilast. Doing well, you can see the clearance of the nails as well as an improvement in arthritis. So why are these rare forms challenging? I mean, the clinical case, what I illustrated shows you that it's a really tightrope walk for the clinician as well as for the physician. And why are they challenging? Because they have atypical presentations, lack of specific diagnostic criteria, associated comorbidities, lack of set guidelines for management, and lack of resources for research. To add to it, we have the social, which has already been talked about lots. There is a lot of stigmatization about psoriasis, misconceptions, negative prejudices, and discriminatory behavior, which contributes more to the challenging aspects. Now, this was a good article which was published on what are the unmet educational needs and clinical gaps in the management of GPP, where there have been factors where at the macro level, meso level, or also at the micro level, which could be at the regulatory, economic, and system level factors, occupational or hospitalization factors, organizational factors. Like this is where I think IADVL, hospitals, multidisciplinary approach, these are areas where we can target for, and individual healthcare provider also, because India has a huge bulk of private dermatologists practicing and who deal with these rare diseases, and they are also not in a clue as to how these can be managed very effectively. Now, coming to each of these forms, what are the therapeutic options which are available, and what are the newer ones which are being used abroad, and which will take a really long time for us to come in India, but hopefully we get at least some biologics which could help our patients, like how I showed my case, who improved very well with Secu. Now, this was for pustular psoriasis. We usually think of cycloacetretin, methotrexate, or biologicals along with topical and phototherapy, maybe systemic steroids, even in cases of pregnancy. The newer molecules which is available, the latest one which has received the US FDA approval is spesolimab, an IL-36 inhibitor. IL-23 and IL-12 inhibitors have also been used. Another concept which is coming up is the tweak related factors, which along with TNF-alpha and IL-17 may play a pathogenesis factor as well as help in the therapeutic option. Coming to erythrodermic psoriasis, again, we have cyclosporin and acetretin as a standard line of treatment, followed by methotrexate. But nowadays, a lot of biologics have been used even for erythrodermic psoriasis. And this has been a good original article which states that a lot of biologicals can be used and are effective in erythrodermic psoriasis. Apremilast, though in Indian population, there are a lot of side effects initially when you start the dose with. There have been reports where they have been used in erythrodermic psoriasis and used successfully. Now, with availability of tofacitinib, maybe that is another targeted therapy which we could look into. Regarding psoriatic arthritis, again, it's the DMARDs, methotrexate, biologicals, PDE4, and the JAK inhibitors which can be used. These are the GRAPPA guidelines, which definitely give a good guidelines, but how we actually apply them in practice, especially in psoriasis with patients who have a lot of comorbidities, they need a lot of reevaluation. Other drugs which have been approved for psoriatic arthritis includes the ustekinumab and as well as the risankizumab. Now, so what are the challenges faced? So the challenges are faced even by us as healthcare providers, because we do not have access, or even though we have the knowledge, we are not able to provide our patients with the best possible care. And even there are challenges faced by the caregivers because of the lot of stigmatization which is associated with psoriasis. And topmost, this is who faces the most is the patients. So when we have patient advocacy support groups, these are challenges which can be overcome, but it needs a united front, which is what we are trying to achieve now. So we need to do things at a macro, meso, as well as at a micro level. How we go about it is something I think this panel and future events will definitely help us evolve better for better therapy for the patient. Now, as a healthcare provider, what I find most difficult is how to tailor the treatment based on the patient needs, because it's not only the disease, it's the financial aspects which many a times tell you as to how you need to treat the patients. And the financial aspects is not only for the treatment, it also involves investigations. So we need to involve the insurance and policymakers for providing biologics and biosimilars to be included in the policies so that the patients can access them. The patient also needs to be educated regarding the adherence for the treatment as well as lifestyle modifications. Now, as a healthcare provider, we have time constraints because we have a huge OPDs, especially in public hospitals. So there are constraints for counseling. So if we could have educational programs which are made and which can be put on YouTube, what has already been told by Dr. Rashmi, or nowadays all our patients are mobile friendly. So if we have a registry for psoriasis and if this can be taken to them, it would really help in overcoming these challenges, which has also been advocated by this publication, that the educational program definitely helps in reduction in PASI, DLQI, as well as the psoriasis disability index. So we need to have patient support groups, health education program, and all this will help to address the needs of the patient and caregivers. And we need to have research for affordable, safe, and targeted therapies. And policy decisions need to be made so that these affordable, safe, and targeted therapies are available to all psoriasis patients, and also the special population, including the pediatric, elderly, and the pregnant patients, as well as the rare forms of the disease. When we talk so much about all this, what is most important is implementation. But there is always hope that, all of these meetings will help us to implement with new emerging treatments and the support groups which will be formed. Thank you very much.
Thank you very much, Dr. Vishalakshi. And you rightly highlighted the importance of rare psoriatic diseases, whether it is pustular psoriasis or erythrodermic or psoriatic arthritis, and what need to be done in this direction. I believe, though these are rare forms of psoriasis, but we do see large number of these patients because of huge population in the country. And as a dermatologist, perhaps we should be doing more clinical research. We should try to publish more epidemiological data on these variants of psoriasis so that they can get recognition and also due attention by the policymakers that there are a significant number of patients who need specialized care and specialized medications for these variants of rare psoriatic disease. So thank you once again for joining us. Now it's my pleasure to invite Mr. Varun Verma, who will be telling about his experience with the disease which he has been suffering since childhood, and also what are his expectations as a psoriasis patient from healthcare system and from the policymakers. So Mr. Varun, please.
Thank you, Doctor. Good evening, everyone. My special thanks to Dakshima Health to provide me this opportunity to share my story with everyone present here. So my psoriasis started when I was around 6-7 years old. I was coming home from school and I noticed a deep cut on my right thumb. So I just thought that it was just a small injury and put some antiseptic creams on it just to, taper it. But eventually I saw that cut was not curing and I saw it to be, I saw some sort of inflammation. We went to doctor, they said it's just a cut. And eventually I realized that it was just not a cut. And then I moved on to different sort of treatment. Many said that this was a skin problem. Some doctors said that it was not. That time was really confusing for me. So eventually it actually took a shape of a skin problem and covered entire hands. So I went with the homeopathic treatment initially. At that point of time, I realized that this problem is known to be psoriasis. So after a series of treatment for about 1 or 2 years, I went to this place in Hisar. I don't remember correctly, but he was providing some sort of Ayurvedic treatment for psoriasis only. But that medication was not, let's say, truthfully in nature, and he was not a very good doctor. So that medication actually increased my problem so much that I was to be hospitalized immediately. I went to PGI for the first time at that time. So when I went to PGI, I met Dr. Sunil Dogra, Dr. Kanwar, who initially handled my case, and they started with steroids, Folitrax, cyclosporin. At that time was really difficult for me because I was not only struggling with my health disease, but I was also struggling with my studies and other problems as well. And this problem really interfered in my social life. Really, there were not many friends to whom I could talk about, but eventually things got normal. So when I sorry, so eventually when things got normal, I was going with methotrexate and cyclosporin only till 10th standard. And at that point of time, I was introduced to biological treatment. So initially, I was very skeptical about the treatment. I thought that this treatment has a lot of side effects. So I thought that it was not a right move for me to, go for biological treatment at that young age. But after I completed my board exams and I went to my 11th standard, my skin problem inflamed again, and that too on a very aggressive level. So the only choice that I had at that point of time was to go with biological treatment. So the first biological treatment that I went with was Alzumab, but the results were not very significantly, uh, they were not very visible, although I did saw some reduction in my redness. But then we went for Secukinumab, and my God, the result. Uh, I witnessed my skin to be, as normal as I could imagine in just second week of administering this medicine. Dr. Sunil Dogra was always there to support us, and till from that point of time till date, I have been taking Scafo, and there hasn't been a single side effect, and that medicine has changed my entire life. I managed to, complete my higher education, and it was a really big challenge for me because, after you are suffering from psoriasis, and medicines can give you certain level of relief, but they cannot cure that disease, and the effects that disease has on our life. The major problem that I faced with psoriasis in my life was that earlier, in terms of education, I was unable to, complete my exams properly. And after that, I even faced issues while learning things because most of the time I was unable to cover up my entire syllabus because of this problem. The second thing that I would like to share that initially I was unable to get any sort of insurance for my health, or maybe to cover my medical insurances as well. So that was a really big challenge for me. Until date, it continues to be one. So that was my story, guys. And I'm really happy that I was privileged enough to share it with you. And it was really nice to see all those reports from doctors, I mean, this research, the researches that shared today were really useful, and I hope all the psoriasis patients could get benefit from these meets and these researches one day. What I hope is that all the patients should get benefit of biological treatment in India because they have far better effectiveness than any other medicine that is available in the market right now. So thank you everyone to give me this opportunity.
Thank you, Varun, for joining us and for sharing your experience. And I'm sure such is the voice of all the psoriasis patients and feelings which you have conveyed on behalf of psoriasis community in the country. So thanks once again. Now, going forward with the discussion, I can continue with you only. If we ask you what change do you wish to see in the healthcare system in the country, which would help patients or benefit patients, say over the next 5 to 7 years. So what do you think, what difficulties you have faced and what you would like the health system to change for the betterment of psoriasis patients?
The primary thing that I want to change in this field, that every patient should have availability of biological treatment at the right price. Most of the patients are not looking forward for this treatment just because it is very costly. Even I find it to be very costly, and its affordability is really a big challenge for me. The second thing, that patients should be educated about the problem on a larger scale, so that they could get their insurances in time, maybe when the condition is not very visible, so that they could cope up with their future, because it is a chronic disease and there is a very slight chance that it will be cured properly. But if patients will be able to get insurance in right time, maybe they will be able to afford biological treatment properly, and it will help them to cope up with disease better. So that would be the things I would like to see change in next 5-7 years.
Okay, thank you. Biologics, though they are very effective, very useful, but they may not be required for, say, majority of the patients. Majority may be managed with topicals or conventional systemic options. But you are right, patients who need biologic, they should have easy access, relatively easy access to them. And economic constraint should not come in the way of having access to costly medications. Thank you. Thank you very much. I think that Ratna, we have very less time. I will take up just one question with other panelists, one each. So, Dr. Rashmi Kumari, in case I can ask you, do you feel there are sufficient studies, not only on the rare variants, but on the normal psoriasis in the country, and epidemiology, clinical features, and what should be done as we dermatologists are concerned?
Thank you, sir, for the question. Sir, regarding clinical data, as we are all pretty well experienced with the routine drugs, we don't need further studies for treatment for methotrexate, cyclosporin, acitretin. There is good evidence, and we know that most patients will have not only PASI 75 but PASI 90 also by 8 to 12 weeks. Regarding the epidemiological data, yes. First of all, prevalence only is hospital based. There are only 1 or 2 I found which were, including in the population. And the patients which we see are mostly either moderate, severe, or they have been treated for years when they were mild, and they come to us when they become really bad. So the burden is definitely highly underestimated. There is no doubt about it. It is as common as diabetes. The rarer variants or the severe variants, the percentage is much less. So I think there should be research in that area. Regarding clinical trials with the newer biologicals, true, sir. What Varun said is correct. Cost of treatment is high, and biologics are the kind whom you may go into remission, but many times the moment you stop it, no, it will relapse back. So I think we as dermatologists have to have the alternatives when we rotate the patient from a biologic to a cheaper biologic like etanercept, or to other conventional drugs if they don't have contraindication like methotrexate or cyclosporin, or much better milder ones like apremilast or um, tofasnib. So and they are also very cheap. So that kind of research, clinical research, is needed, sir.
Okay, thank you. Dr. Vishalakshi, if I can ask you, how professional organizations like IADVL can help to improve the patient access to treatment, the treatment outcomes, and maybe more research in psoriasis, maybe networking with the policymakers. Your thoughts on this?
Yeah, I think this is a very good thing which IADVL has started, and we have to thank Daksham also for involving us so much into this, because patient advocacy is very important, and we can form even patient education modules, and in this recent era, even creating YouTube videos which are very accessible, and like how Dr. Rashmi suggested, like since with the experience of COVID vaccine, if we have some software company licensing with IADVL and the psoriatic patients, and you can create a psoriatic patient registry through that, like, I mean, if you have, I mean, as an association, because we are the experts, we can put in which are the specific subsets of data what we need from the patients, which would help improve the condition for them. It may not be a total cure, but even the mild to moderate forms, they roam about in so many places and they are so misguided and get into oral steroid treatments and things like that. All those things can probably be tackled if we as an organization are more proactive in this manner, I think tie-up and uniting is what we have to do.
Yes, I agree with you.
Sir, can I say
one line? Dr. Ratna, please. Yes, please.
Yeah, just to add to what Varun said, so I was diagnosed with psoriasis in 2006 and have been living with psoriasis since then. And of late have been having some symptoms of arthritis as well. Now we, as a family, are an ECHS beneficiary, and when we go to an ECHS polyclinic, there's no dermatologist. So it's a general physician who generally has a look at me and then refers me to two different specialties in two different hospitals, where there is no sharing of data, and it is very hard to get these two specialties to talk to each other as well, because the appointments are not on the same day. So as a patient, I not only am running around 3 hospitals, the ECHS dispensary, a rheumatologist, and a dermatologist, but also trying to see what kind of prescription I have received from each of these specialties. So I think there has to be some kind of coordinated mechanism to be able to manage patients. So as a person who is clinically qualified to understand what prescriptions are coming to me, I have problems sorting out the prescriptions and going back to the doctors and say, this has already been prescribed, so please don't write this once again. Or the ECHS clinics looks at the prescription and says, okay, you have received a prescription here, so we are not going to repeat it. We'll give you only a dosage for 1 week. And for a common man, this must be mind-boggling. And this must be happening for all places where such referrals are happening, whether it is railways or CGHS or any other system where a referral system is in place. I think there needs to be some work done, because these are patients who are eligible for treatment. They are not really paying out of pocket. However, the system is not well coordinated, and I think some coordination mechanism needs to be built here.
Yes, I think you raised very important point, and we have seen some patient getting the toxicity with the drug when the same drug was prescribed by a rheumatologist and a dermatologist. So they ended up taking double dose of, say, methotrexate. And answer to such a situation would be a combined dermatology-rheumatology clinic or something like that. So I know some of the hospitals have started working in that direction, but maybe a more number of institutes and hospitals should look forward for such combined clinics, and that is very relevant. Yes.
Also, I think Dr. Rashmi's point about using digital and technology to advantage could possibly help. If we have a registry, we can track what patients are taking and be able to put in some guidelines so that, maybe there has to be some kind of a some kind of a guidance document or a flow chart which tells the rheumatologist or the dermatologist you should ask whether this person has gone to any other doctor before coming to you, and show your prescription, because we are still paper based in many hospitals.
So NDHM has that facility. See, every empaneled doctor will have all the treatment records of whichever patient who is visiting any doctor, and they will know the record. It's like a centralized record keeping. So that facility will come if government continues with the scheme. Sir, I wanted to speak that registry should be patient based. There are many patients who are willing to tell, I suffer from psoriasis. I have this much percentage area of skin involved, or I have joint involved, and I am on this treatment. This information patient can self-declare, and that registry is likely to be much more successful than asking doctors to be, doctors can give, hospital-based registries can be there, but it'll be much better if there are patient-based registries.
I agree totally, because hospital-based registry may not address the actual problem which is needed to be addressed, whereas the patient is the one who is the core, at the core. And in the end, we are doing all this for the patient. So patient-based registry is what is needed. And with COVID, I think we have understood what technology can do. So
the government took care of it. Every counter was there live with a website.
So I think we can do it.
So any other point or any other?
Varun
Yes.
wants to say something.
Varun, yes, please.
Yes, doctor. Actually, I forgot to add one point. I think Dr. Ratna edited her presentation that psoriasis isn't covered in any disability act, which is really a bad thing, because it should be at least a part of of that act, because it helps us to as a patient. It could help us in many ways. For instance, in college days, I was not allowed to have extra time during my examinations, and because of that, my percentage was really affected. uh, where I managed to get almost 86% in my 12th standard. I was just a 70% student in my college days, and that was a really disappointment for me, because I couldn't perform to my maximum efforts.
But
So
in this, Varun,
yes.
I would like to say that disability percentages are calculated based on permanent disability. The thing about psoriatic arthritis, if it has caused a deformity, you can get that percentage. Government will agree to it. Like for leprosy, even if you have a foot ulcer, you're not able to walk. As long as it's permanent, they give you a percentage that you can't walk, you can't work. But psoriasis skin lesion is going to go away. So
Yes.
you can't get a permanent certificate.
Yes.
So anyway, the benefit as in non-communicable chronic disease, I think that should be given to all the
That
patients.
should be given,
Because
yes,
that is lacking.
Yes.
Yes, so that is most important. And patients who have deformities because of this, say, psoriatic arthritis, they may be entitled for the disability also.
Also, this perception of invisible disability, meaning chronic pain is also a disability where nothing is lost, but you cannot really function. And there is more and more recognition that arthritis, chronic pain, etc., are disabilities and should be included under the Disability Act. At least worldwide, there is a lot of discussion around it. That kind of discussion hasn't been initiated in the context of our country. Maybe it's time we did that.
Also, rail concessions. See, rail concessions are available only to cancer patient, leprosy patient, is
Lot of patients now, even hemophilia,
So,
thalassemia. Yeah.
the psoriasis patient actually, even on systemic therapy, needs to come and visit a doctor only once in 3 months, once they are stabilized. So they don't need to have investigations also very often. But with the increasing bus charges and dermatologists not available nearby, if some rail concession also we could provide, that also we can work on.
Yes, I think so.
Yes.
Yeah.
So thank you. I think all the speakers, panelists, and since we are running behind the schedule, Dr. Ratna, can we conclude this session? If you have
Yes, sir.
any important point to convey, please you can do. Otherwise, Tamanna, can I have next slide? So it's my pleasure now to invite Dr. Dinesh Kumar Devaraj, who is the Secretary General of our association, that is IADVL, and he's also Secretary of International Society of Teledermatology and had been Secretary of so many associations like Association of Cutaneous Surgeons of India and Indian Society of Teledermatology. And he's past Vice President of IADVL Tamil Nadu branch, and he is a speaker in many national and international conferences. So I request Dr. Dinesh to give the vote of thanks and the concluding remarks.
Thank you, sir. It was a very interesting discussion, and I think everything has been comprehensively discussed and threadbare, and we have had a very fruitful discussion. So basically, the three main things that we are looking at is how IADVL can play an important role in building up the psoriasis patient voice and to help the patient support groups, and what strategies IADVL and the patient support groups should adopt to build up the patients' voices and for their voices to be heard at the government level, at the policy level, to be implemented. And what are these strategies that we should adopt so that psoriasis gets recognized at the policy level, like the national health policy, the insurance, and the insurance claim. So it was on these lines that the discussions were made, and it's been pretty fruitful. And just to summarize, what we could possibly do is I just want to say that this is the first time on a national scale we are doing this on IADVL patient advocacy program. We have done in my capacity when I was the secretary of the Chennai City chapter. We have done such programs right from 2012, where we have had physical programs where the patients were invited on the World Psoriasis Day, and we have been conducting, and there have been huge success. We have invited policymakers also. The important thing is we discuss among ourselves, but it's high time we invite policymakers into the discussion, the government officials, the bureaucrats, the IS officers. These are people who are really into discussions, and I've had many discussions with them. And it's for them, what I've sensed is it's always the diseases which have a high mortality, which really catch the public, which have a dramatic effect on the public's mind, like leprosy or something like that. That is where they are more focusing on. Though psoriasis has much big public health burden, and if you look at we discussed about the financial liabilities on the patient and the family, how much social impact it has, it's much higher. The prevalence of being 2.8% is much higher, and the patient suffers a lot, the family suffers a lot, and there's a lot of other problems associated. But this is really pushed under the carpet because the psoriasis as a disease is not taken seriously, and we are not being able to lobby well. So I think it's high time we lobby well. And this World Psoriasis Day, I think we should be making it a very national affair, trying to make such programs on a very wide scale basis, so that every city, every town is done, and IADVL can really liaise with all these patient advocacy groups, the patient support groups. We are ready to offer our help. We are ready to provide the material. We are ready to provide the database. We are ready to help create the registries. Whatever scientific data is needed, we will do it. And from the patient support group, we need your help in lobbying with the government. We need to put a united effort in lobbying. We have lobbied with the government on various fronts, like topical steroid abuse and quackery and stuff like that. And it's high time we try to get this was discussed with the government about the getting biologicals under the insurance in 2018, but slowly there was a little bit steam was lost. But it's high time we get back to it, and I'm sure with the joint efforts and consistent help by the patient support groups, we will be able to do it. And one more thing I would like to say is the patient information. I think we should be thinking in terms of having a patient helpline, something like that. It could be a dedicated website. It could be a patient helpline, a phone number where patient could get authentic information. Now, this information could be backed up by IADVL data from IADVL experts, and the patients advocacy groups could help to popularize this both in social media and mainstream media. The mainstream media really makes it much more serious and much more acceptable to the people. So these are the ways the patient support groups can also help us, and there should be more people talking about it, more people talking about how this is going to affect the public and the public health burden of this. And also on the drugs are getting much better with lesser side effects, and also the affordability is also getting better. And here again, I would reiterate, in the state of Tamil Nadu, we have the government hospitals supplying biologics free of cost, which is a very big boon to the patients. So it's high time both the other states implement this, and even the central government brings into this. All these go a long way in impressing that psoriasis, we would definitely have a better accessibility to newer drugs. And also we will try to get it under the insurance policy. Now, each department is different. For example, you need to talk with the health department, you need to talk with the insurance department. So we need to have a consistent effort, we need to have a plan of action. So in this direction, I think both of us, both the advocacy groups and IDVL, can coordinate. So I'm happy we have started in the right direction, and I just hope this continues, and we would be able to hold on and to this effort, and build on more on this particular effort. And I thank the Daksham Health and Education group for their support in this program, and also the COPS, that is the Community of Psoriasis Survivors, for partnering with IIDVL in conduct of this group, and the technical team for the conduct of this program. I thank the speakers, Dr. Rashmi Sarkar, Dr. Vibhu, Dr. Ramesh Bhatt, Dr. Ratna Devi, Dr. Sunil Dogra, Dr. Rashmi Kumari, Dr. Vishalakshi, and Mr. Varun Verma, and also Ms. Tamanna for the back-end support and coordination with us. Thank you all. If you have any doubts, always you could write down to us. You could stay in contact with us. Thank you all once again. Have a good night.
Thank you. Thank you, everyone.
Yeah, bye-bye.
Thank you so much.
Thank you. Bye.
Thank you. Bye.
Bye. Thank you.
Bye. Yeah, thank you very much.